Good morning, colleagues. We are going to be starting session 4. The topic of session 4 is reshaping and investing in a multidisciplinary and intersectorial public health workforce to achieve SDGs. Colleagues, may I have your attention, please? We're going to begin session 4. This is a hugely important topic because without workforce, really, we cannot achieve any public health agenda. So WHO last year estimated that we are short of 14.7 million people in the healthcare workforce. A daunting number. And yet we have so many unemployed people in the world. What are we doing wrong? What do we need to do differently? This session focused on the HR capacity building, and we have my co-panel chair, Dr. Felix, and my esteemed panel members. And with workforce, we not only need the number of people, the correct cadre of individuals, we need the right competencies, we need them to ensure that they have the skill sets, that they are attracted, that they are trained and retained in their services, that their roles are defined, and that we don't forget the forgotten healthcare professional, and I call them healthcare professionals, but these are your support network. The medical technologists who need to switch on and plug in the ventilator. The IT professionals who ensure that the surveillance data is transmitted. The communication officers who support the healthcare workers' communication strategies. So with that, I'm going to hand over. Prof. Felix, would you like to, Dr. Felix, want to say anything? All right. So our first speaker then is looking beyond traditional health, public health cadres. And Prof. Amir, I'm going to hand the floor to you as the Vice President of IANPHI to share with us your wisdom.
Thank you so much. So primarily, a big thanks to Mozambique for organizing this event. Now you know the theme of this, so we'll try to cover up in a very short time, whatever possible, and exploring interdisciplinary approaches for a resilient public health system. And that's what we require. And it's a big requirement under the changing environments coming out of a pandemic and moving on. So public health has traditionally been focused on the medical and epidemiological expertise and gradually moving on to dental and veterinary, and with the concept of One Health, again moving on. But I think the emerging demand and challenges require much broader approaches, and that's what we discuss. We all truly know the essential public health functions, and with all that in mind, as we move on, we can divide them into different ages, and in particular, 4, I would say. From the ancient and early era, we started off thinking about, and then moving on to the sanitary age and all that with the germ theory, and then moving on to the public health, economics and other divisions, and finally to the new public health, as we can see, the holistic view of health, mental, physical, and social well-being. And that goes much beyond the current human resource and expertise. This is an ideologically integrated public health network that we always do, and you can see and focus how much of public health force is required. With WHO standing by, and we heard this morning that IANPHI has always been there as a support, and it remains, I would say, a strengthening arm to WHO and the WHO Global Hub in Berlin for the strengthening of the NPHIs. The TEFINET, on the other hand, is directly dealing with the FETPs. So it's the human resource component and the outbreak component go on. And definitely the newly launched post-pandemic GHIC and GFIP. But beyond that, there are a huge number of bodies, whether it's the vaccine, or talking of Gavi, CEPI, PV, whether it's the diagnostic side with FIND or other donors and partners. But coming down, finally focused to ministries of health and the institutes within the countries. So all these require the public health force expertise. The changing scenarios, again, are something we need to take care and talk about with the globalization and emerging challenges. Rapid travel, disease, climate change, we heard a lot about that. Moving on to health systems and policies, starting from all matter declaration, where we talk health for all, moving on to the Lusaka agenda, I think, which again talks of universal health coverage and in particular, elevating the standards of primary health care. Health in all the policies is again something very, very important. Equity, we hear a lot, we talk a lot, and I think on-ground implementation with the WHO Commission on Social Determinants of Health and other available documents, the inequities within and between the countries as well. And looking forward to the new technologies, the genetic epidemiology and precision medicine as well. There's a long list of people. And why I say it? Because once we know the challenges, then we can accordingly train the human resource. Antimicrobial resistance, I think one of the key challenges for this century. There's always a resource limitations, and I think under the current financial constraints that are evolving, things may become more difficult, and that's where we need to stand together to formalize. I mean, Lusaka agenda talks of, I think, one agenda and one proposal that really works well with the developing countries. Health inequity, we talked about huge technological advances with the use of AI and all other things moving on and on. And I think some of the key areas remain with the policy and regulation. Here's yet another area where we can help a lot with the WHO and to the NPHIs as well. And then we have the aging population that definitely increases the non-communicable diseases percentage, talking of mental health as well. And we have huge communication barriers at times, though there's no dearth of social media. But I think with language and cultural barriers, at times it becomes difficult, and we have to deal with misinformation side by side. So what is the new public health? Well, I just would briefly like to say that public health has evolved as a multidisciplinary field, and we need to have multifaceted approaches in this regard. And talking of use of basic and applied sciences, education, social sciences, economics, management, communication skills, and directly or indirectly promoting the welfare of an individual and in general, the community. Now, this thing is something very, very important to understand. And that's why we look beyond the traditional cadres. And COVID pandemic, I think, was a huge challenge, but brought in many opportunities. And I think it was all, again, a combined effort that we could manage this little virus, which really drastically changed the world, the concept of health, and as we move on. So many emerging threats that require diverse expertise. The digital transformation depends on new skills sets as well. The interdisciplinary collaboration enhances the system resilience. And that's what we talk. We talk of the health system resilience. And that's, I think, again, a combination of multiple expertise brought in together and working together. And addressing the health inequities also, and creating the next generation of non-clinical public health force. And I think I can give example. Even in our own country, moving after the post-pandemic, there are people from the data side, management side, who got interested, and they're doing the masters and other degrees in the public health as well. So expanding the public health forces, you can see, the data scientists for predictive analytics and disease surveillance and modeling. This is something very, very important as we move on. The behavioral scientists to address the social determinants of health, and then moving on to the environmental and climate scientists. And I think we have already heard a lot about this thing. And I think some of the game changers up in the post-pandemic are climate, One Health, and AMR, which need to be addressed again accordingly. Pharma has got a huge role, and I think we have seen a lot during pandemic. And as we move on, the rapid expansion, the changes, the new treatments available, the discoveries and clinical trials got an extensive role over here. Policy and governance, again, I think this is a key area, because I think whatever based upon the evidence policy comes down to the governmental level, and it's for them to truly understand the meaning of that and translate into policies again, and policies which are implementable. And we've got so many frameworks, but one size does not fit all. So according to the country's requirement, regional requirements, and we need to transform the policies. And finally, the communication and media specialists combating the misinformation. Now, a role of digital technologies, we are all well versed with the AI and machine learning, predictive models, moving on to digital health records and patient care, taking the patient care and tracking. I think this is something, again, becoming important, especially in the LMICs, which were lacking this facility earlier. And telemedicine going beyond, I think, to the far-flung areas, and yet another example where it helped a lot during the COVID. And blockchain and cybersecurity, ensuring securing the data management, which is again a very comprehensive thing. A little bit small case studies that WHO digital health initiatives. We have Dr. Sohail with us. We heard this morning as well. So I think the different tools, they can really help us a lot in this regard. And again, according to then modifying according to the dimensions, requisites within and the circumstances within individual countries. One Health approach, the pandemic response, leveraging technical professionals and the data scientists together, and community-based solutions engaging traditional actors in the health advocacy. So we will definitely come across many challenges, because the most important would be the resistance to change within the traditional system. And this always happen. And I think that I think a lot of credit goes to change management launched a few decades earlier, which had helped us a lot in understanding and gaining the momentum in different fields. And then talking of limited training programs for the non-traditional. And here is the area where we need to talk about through IANPHI, through other bodies like TEFNET, to move again beyond the traditional human resource. Data privacy and ethical concerns, definitely in the modern age, are a big issue, and funding constraints will already facing a lot. So if we talk of getting more momentum into this, definitely we will face this challenge a lot. And I think one of the key areas in inculcating this interest in the non-clinical areas, and not only that, maintaining that interest and providing them those opportunities, that's the key to hold them on in this regard. So the way forward is create next generation of non-clinical public health workforce, encourage cross-disciplinary training programs. And I think this already started happening in certain countries, and we need to take it, I think, as a global challenge. Then integrate the digital and behavioral sciences into the public health curricula, which already exist. And I think we can add a lot to the existing human resource, foster collaboration between health, technical, and policy sectors. And this is more important for the policy makers to understand, and invest into the digital and AI-driven health solutions. And definitely this will all in all go to the strengthening the communities of shared practices as far as the cross-disciplinary collaboration is concerned, and further to have the continuing learning as well. So just to conclude that public health must evolve beyond the traditional roles to address the modern challenges, and interdisciplinary approaches can enhance health system resilience and equity, and strategic investment in technology and capacity building are essential now and for our future and for securing our future generation. And we definitely talk a lot about the global health security, and we did hear from the Korean side the model that they have established. So it's always a teamwork. Thank you so much for listening, and let's work it out together for all these things. Thank you.
Thanks, Prof. Amir. I mean, I think you raised some hugely important philosophies of the new public health workforce. Well, one fundamental principle is, where do you find the budget to do all of this? And I think that's certainly going to be our biggest challenge. There's time for discussion later. And our next speaker is going to be Dr. Jeffrey. Is he online? He's online? Okay.
Yes, I am.
Ah, wonderful. So Dr. Jeff Namaro from WHO Berlin Hub online, and he's going to be talking to us about the strengthening of peer learning between NPHIs. Jeff, welcome, and thank you for being online. We look forward to your presentation.
Thanks, Dr. Natalie, and thanks again to the IANPHI team and the MOS team for our invitation. Delighted to be part of this. Again, our apologies that we're not able to join in person. Would very much have loved to, but greetings from the entire NPHA team at the WHO Hub for Pandemic and Epidemic Intelligence. Can I confirm you can hear me loud and clear and you can see the slides? Okay, I will continue. So colleagues, as you heard from Dr. Chikwe yesterday morning, the WHO is getting actively involved in the National Public Health Agency or Institute initiative in terms of strengthening capacities of member states around health emergency preparedness and response. And one of the pillars that we look at is strengthening peer-to-peer learning amongst national public health agencies. Over the next few minutes, I'll briefly share about the exchange program that is currently in the works. This is something in design that we are hoping to activate probably very soon. Over the next couple of months or even early next year. So briefly, why is the need for this? One, there's quite significant demand for increased engagement amongst the institutions that we call either NPHAs or NPHIs. And understanding the diversity of these institutions, both in governance, in financing, they very much need to engage more with each other in fora such as this very one, but also appreciating that significant work has been done, especially by IANPHI, that we can leverage on as WHO, who've not actively been involved, I must say, previously, but now very much so. There's opportunities to leverage on to build on these exchanges further. The objectives of this initiative or the exchange program is essentially to promote or build onto the existing technical and leadership capacities of NPHAs by bringing them closer even and building long-lasting connections between these NPHAs. As we've seen so far in the previous interactions we've had, MOUs have come out of some of these NPHAs. So briefly, I'll share the three models that we are looking at. One being the mentorship program, that's pretty much the traditional approach of fellowships that we've used. Then a peer exchange modality, and then a public health challenge modality. I will briefly explain what we are thinking in each of these, and of course, happy to discuss further, happy to build this further. The aim of sharing this, even when it's still in the design phase, is so that we can get input from colleagues such as you. So on the mentorship program, the objective really is to share the critical knowledge from the mentor institutions and build that contact between the mentor institutions and the mentee institutions through sharing expertise, through sharing knowledge on the different approaches in the different contexts. And the process we're looking at for this is WHO, the hub or the health emergencies program, in close collaboration with partners such as IANPHI or any other partners that may be very much interested in this space, would put up a call for expression of interest, first to the mentor institutions to highlight areas that they would be interested in to receive mentees. And then following identification of these institutions, then the call for the fellows or the mentees would be put out. And then the partnership would jointly conduct the selection and matching process. The key slight difference between what we've traditionally done and what's currently happening across both from IANPHI and several other institutions is we have identified that there is need for the identified mentor or supervisor from the mentor institution to first spend some time at the originating institution, understand how their institution works, and then the mentee would spend maybe 3 months at the institution, and then after at the end of the visit, the mentor would also again support the mentee through maybe a 1 to 2 week visit to the institution through which the mentee left. This is building onto what's currently existing, and the role of WHO and the partnership here would be to facilitate that exchange, increase the visibility, leveraging on all the existing work that's so far been done by groups such as yourselves. The second approach is the peer exchange. So the key difference between the first and this second approach is this is targeted more to sharing insights between the two institutions, and how do this either at technical level or at policy level, where we have, say, mid to senior level management actually swap. So one public health institute would send, say, their surveillance head to another, and the other also sends their surveillance head this way. So they do swap for a period of maybe a shorter period, probably not 3 months, so that the disruption is not significant to their different pieces of work. And this would also go through the same process of calls for expression from the different institutions, and then a selection process, identification of the pairs. As I mentioned, the pairs could be either technical, but could also be policy level or management level. And then a negotiation process on an ideal timing through which this can happen. The third and final one that we're also looking at is a joint public health challenge. So here the aim really is to facilitate collaboration again between these institutions to address common felt needs and gaps of, say, public health challenges. And this would help to generate, say, public health innovations. The approach to this is also a call for expression or a process of identification of a common challenge that probably affects NPHIs. It could range from the different pillars, the surveillance to RISCOM to case management to broader institutional challenges. And then NPHs who would be interested would come together with clear timelines, deliverables, And then WHO and partners, you will realize this is all designed to be a partnership. It would not only be facilitated by WHO, but WHO and partners who could be identified would then facilitate a process where they would then come together. So WHO would facilitate that process where they would come together initially for, say, an initial in-person meeting at a location that is considered suitable. This could be, say, the WHO hub, or it could be at another location. Agree on the processes, agree on the terms, agree on what's going to be done, and WHO would facilitate this whole process. Then they would continue this process virtually, regularly meeting online to complete their assigned tasks, and then later on follow up again in person discussion where they again come together and then agree on the outputs, or disseminate the outputs, or evaluate the next steps. So this is bringing together NPHIs to jointly address a common challenge, and then the partnership facilitates that whole process. We believe that the benefits of this really would, of this exchange program that has the 3 sub areas, would foster bilateral institutional relationships, as we've so far already seen in the meetings that have been hosted. Lots such as these, lots of these bilateral strengthening opportunities do appear. So this is building onto that. It is also key for strengthening capacities of NPHAs, underlining their technical capabilities, but also improving the visibility of the role of these NPHAs and the collaborating partners in these networks. When we say partnerships, we are keenly looking at, say, IANPHI, the other national public health agencies or institutes. We're also looking at the role that our regional offices would be playing in this, and other key partners that would be of interest. With that, I'll stop there, and back to you, Chair.
Thanks, Jeff, for sharing those insights. Really significant developments. And it's certainly aligned with the peer learning key strategic objective of IANPHI. That over the years, the strength of IANPHI lies in that collaboration and cooperation. So thank you for sharing that. I'm going to hand over to Dr. Shiva. And Dr. Shiva is going to be discussing essential public health workforce and WHO roadmap and investment in essential health public health workforce as part of the strengthening of NPHI's workforce for sustainable development. Dr. Shiva, over to you.
Can you all hear me? Are you all ready for a public health journey? Now we are talking. Colleagues, friends, and comrades in public health, it's a pleasure for me to stand in front of you. It's a long journey to focus on 2 things: people and professionals, which is now called workforce, public health workforce. Without this, as you saw this morning, everything which happened this morning was dependent on the people and the professionals. The General Assembly, if you reflect, and yesterday's presentation by 2 powerful leaders in Africa and globally. Dr. Kaseya, if you reflect what he said, also if you reflect a little on what Dr. Chikwe and a lot of us here also presented, and it was summarized very well, and I listened to Dr. Ott, Dr. Bernardo, Dr. Ikram. So my task is here, standing in front of you all on behalf of the subcommittee which was created. I don't know how it came about, but I sort of joined it and then ended up being the chair since last year because of my passion for public health workforce. When you have the people, you always succeed. And you have the right people with the right commitment and motivation, they will always qualify and become more competent. So that's why I'm here on this very critical aspect. We are in a historical movement. Globalization is gone another direction, or is going in another direction. But when you listen to Dr. Pamela this morning from the European Commission, she said not global health, she said global public health. And my appeal to all of you, including the new secretariat, all you have to do to make a success, because I can see the transition of the old secretariat from Institute Sante to Robert Koch, as well as we all part of it, put public, global public health.
Vâng, thế thì phải thêm ông nói cả tu hương nữa cho nó phải phân loại trước đấy đi. Vâng.
It looks like the public is listening. So if we can just put public into the global public health, I have finished my work here. The other thing is putting public health ahead of health, then our job is done. So that's my key message. Again, an area which we all talk about, leadership and governance, but management is critical. And it is inbuilt into all of us. It's a very important element which we need to focus upon. I again emphasize we are in Mozambique, between Tanzania, Malawi, Zimbabwe, and South Africa. This is a historical place which led to independence and freedom in this area, in this part of the world. But we still have to go a long way to get independent and free of diseases and ill health. That requires leadership, not politicians, not parliamentarians, not the public. It requires the professionals, but we don't need to always blame the politicians. My experience of working in the districts, provinces, national level, even globally, if you're professional enough to put across, the politicians will always respect and listen to you. So don't please blame the politicians. They are, however, asking some very serious questions over the last few years. It's from Southern Africa. Because of the burden of infectious disease in Africa, our ministers and policymakers created the Global Fund. Billions of dollars on commodities, very little invested in the workforce and institutions. The same thing with Gavi, same thing now with the pandemic fund. A lot of the bilateral aid, multilateral aid is not invested enough, or even should be the majority, is the workforce. You heard Dr. Natali saying, we have health workers without jobs. So these are some of the questions people are asking decades later. Where is the outcome and impact? Today, the burden of malaria is not acceptable. We are living with cholera, which is what started sanitary medicine or sanitary health in Europe. Malaria was eliminated after World War II from Europe, learning from the challenges of people dying more of malaria. And still TB and leprosy, which was eliminated from the Scandinavian countries, is still the biggest problem in this part of the world. And all you have to do is go south. The highest incidence of TB in Africa is in South Africa. So these are questions we keep asking. And I think we need to also look at the issue of, do we measure health? Do we measure happiness? And I always say, go to Bhutan. They will teach you how to do it very simply. The Mountain Kingdom focuses on happiness and primary health care and public health. You can't take cigarettes into Bhutan. So I think we need to keep focusing on a few issues the public health structures. I'm not talking about health structures. Dr. Kaseya focused on financing yesterday, rightly so, health strategic plans. But what's the origin of Africa CDC? What's the origin of US CDC? What's the origin of the Mexico Public Health Institute? We need to look carefully what those institutions were designed and what they're also doing. So I think we have a lot of experience here to look at the design and strengthen the workforce here. What is the public health workforce? I think we need to be very clear and very focused. Common language, humanities, solidarity, fraternity. Today we are losing a lot of humanity. What we see today in Ukraine and Gaza is no more humanity, or in DRC. And we have to be aware of it and how to deliver and protect healthcare in this situation and health workers. So there's too many language issues, jargon, terminologies, and trying to focus in this globalization, it's very difficult. All you have to do is try and survive. As we say in Zimbabwe, we try and survive sanctions for a long time, which has undermined our economy and our health workforce and is bleeding. But that's because of the issue of independence and freedom. And you can see the same issues in Canada, you can see the same issues in the US, you can see them in Australia, etc. But anyway, we still have to work on how to deliver equity, solidarity, fraternity. That's the basis of what we are as public health specialists or public health workers. From day one, our ideology is service to everybody. So, an excellent presentation from Dr. Bernardo from Mexico. How do you strengthen the education with research? But also, in our thinking, how do you strengthen service delivery with the research and the education, appropriate education and publications? So research without service delivery, training without service delivery, we still have gaps where majority of the population is dying without access to a health facility or doesn't have access to water and sanitation. This is the 21st century. Don't tell me there's not enough money in South Africa or Namibia or in Zimbabwe or in Mozambique. So one has to really think carefully. We are already off track. We were off track with MDGs. We are off track with SDGs. We are off track UHC. There's an urgency. We have a few years. Can we do it? I can assure you we can do it, but it depends on our professional commitment and our collaboration and our common mission to deliver service to all those people who are living today without service, thanks to globalization. This is what I want to leave with you. I will go a bit further, but if you capture these key issues, I think I have finished. As we discussed in the subcommittee, we need to have more and more inclusivity across the globe, from the north, south, east, west. We need to meet frequently. We need ownership and responsibility by public health institutes to have somebody designated who will take this area of essential public health workforce forward. WHO has done what it can since 2003, after many other meetings, but the implementation, as always, is lagging and it's challenged. The other thing is we have had one-way traffic of researchers and others. I think it's important to build a relationship. As I heard today from Dr. Johanna, it's not money, it's relationships, exchanging expertise, experience. That's more valuable than all the bilateral aid or multilateral aid for money. And that's why I hear today as well, you heard, is more how do you work on exchange and twinning programs. Already we have seen this happening in between Norway and Malawi, between Germany and Namibia. That's where we learn from each other, hold each other's hands, and move forward. That's the most success of building people and institutions together and sharing the common problems and common solutions. And then again, the issue of partnership, where it's not as correctly said, when we talk about multisectoral, you need other ministries. Ministries of education is a very critical, ministries of finance. Of course, we always talk about finance, but I'm not too worried about finance as long as we are clear where we're going. Most finance people will invest. But if we are not clear on output, outcome, and impact, most financiers won't invest in us. An excellent model which was presented by Dr. Meck is on the collaboration between WHO Europe and IANPHI. That's how WHO used to work in the past. I was seconded into WHO from the Ministry of Health. I came back to the Ministry of Health and then worked as well. It was a huge motivation. Our secondment between countries, national public health institutes could actually help WHO to reform, which is urgently required because it has also lost a little bit or more of its direction and unable to deliver real public health at country level. And the key issue is competencies, as you heard, and skills of public health workforce. But the most important thing is the motivation or the professional environment to learn, to deliver service, do good research. You said excellent examples this morning, Dr. Ivaldo, excellent work from Dr. Bernardo, etc. So maybe I should go home now. How much time do I have? 1 minute. Okay. She's a very hard taskmaster because we're always looking at her from Zimbabwe, what South Africa is. But it used to be the other way around as well. Okay. Have you all got this skeleton? Oh dear. It's not moving. Aha. Now I'll go through very quickly. The first one is this one. Africa CDC has made a great change, great direction, but we all need to help and work with it at country level and regionally and international level. Africa CDC is really taking things forward for Africa and the countries in Africa. I think you saw the example yesterday. But the key issues is the two fundamental, the new public health order for Africa. Those are the two fundamental areas and the other ones. And you saw Dr. Kaseya leading on that. We are expecting a new WHO Director General for Regional Office for Africa. And I'm sure he will consolidate the work and the leadership which has been put forward by Africa CDC. This is not new. This is old as anything, and it will not be different 20 years or 30 years from now. I work on history of health and public health, and I go through the records of health, and I have gone through the records of my Ministry of Health, and I'm trying to also work with my younger colleagues. Service delivery, service delivery, service delivery. Access, access. That's the key issue. The rest is supportive with the workforce, information, etc., etc. But for not financing first, please, not financing first. Again, the health workforce, key, elaborated by WHO long ago. And then primary health care, the fundamentals of multisectoral approach, health systems building, district health system. The success of WHO is not smallpox or malaria eradication. Success of WHO was primary health care under the legendary leadership of Halfdan Mahler, who was a TB specialist, but also ended up leading WHO to a new vision from just infectious diseases of the WHO created to the WHO's 70s, 80s, and 90s, building health systems, delivering on primary health care and Health for All 2000, which was a definite success, and all the institutional memories in all our countries. But unfortunately, Africa was left behind in many ways, and there's a historical reason. And you ask the question why the WHO office for Africa is in Brazzaville. You ask the question why the Africa CDC office is in Ethiopia. Again, you can update a little bit the old and the new of primary health care, but the foundations of primary health care don't change and will never change. If you are committed to equity, social justice, and delivery. As I said, WHO has had standards and established them, and they're very simple, and has also worked on with primary health care on the determinants of health and performance of the health systems. I don't think I have to go back on this, but sometimes we tend to do the name public health with many things and we can get a bit lost. But the issue of protection, we don't do enough. And Wales gave us a very example of a legislation to protect well-being. Today we have a lot of funding from different sources like health tax or etc., but we don't have legislation protecting the use of the health tax. Sugar tax. And the issue of promoting healthy behavior has now become risk communication, but it's still health promotion. You can change the terminology. But more important is essential public health functions. Again, I won't spend too much time, but again, you can focus on certain areas like pandemics and emergency, but you forget that the principles of pandemics and epidemics and emergencies are all the same. The practice are all the same. We don't have to fragment it and do it a different way. The same thing with different names of the same thing, but can cause fragmentation and parallel initiatives and a loss of outputs, but no outcome and impact. This is what the WHO's vision on essential public health workforce here. Today, WHO has been trying to revive this again and again, but it has not had the momentum from its regional offices and country offices. And more important, the countries haven't internalized it and taken it forward. This is what the Public Health Professional Development Committee is supposed to do, is to work with countries and IANPHIs to go on the public health functions, competency-based health education, and measuring public health occupations. Do we have any country here or NPHI which has taken this forward? Whether in Europe or in Americas or anywhere? Canada? Yes? Yeah, Canada has taken it forward. Yeah, so that's a good point. So just to finish up, the core public health workforce, there's a lot of people around, but you need to focus on a core and a critical mass. And I think we have a critical mass here to make the leadership movement and change from here in Mozambique, in Africa, and globally in public health, global public health, and national public health institutes. Just one point, which was recommended by Dr. Bernardo, the past public health training was inadequate and academic. We have changed it to more field-based. And then we have also now expanding it to more, and there's a platform now in place. We have had a lot of field epidemiology. Then why are we not able to control and eliminate cholera or malaria? Back to the future. Essential public health workforce was there and it's been there before. And primary health care has been there, has proved to work. We just need to move very quickly and implement it. And this is another one which we are implementing as well in East and Southern Africa, which many of you will be linking up or already linking up with the East African community. If I may ask one more minute. Thank you. These are the thematic committees, but I think we need to look at how these thematic committees work in terms of the needs and demands in the region and the countries, and not just from the north, but also from the south and the west and the east, and the reality of public health on the ground, bringing things together, aligning and taking them forward. And then there are other committees which are still required, and I think we are talking about them. I think we started on surveillance. We need to continue. Consistency is important. It's not webinars or meetings or reports, as WHO sometimes today thinks. You have to take it to the ground and apply. There's an MOU. I think you have heard about that before between WHO and IANPHI. I don't think I need to spend too much time on this one. Just to update you quickly what the committee has done since just last, and what the milestones have been from July to December. We have some tools, but we haven't got the money yet to organize meetings in Europe, but I hope ours will be more in the South. And
So, Dr.
that's
Shiva?
it.
So, Dr. Shiva, I think we need to come to a conclusion. You want to just wrap up the last final word, please?
I have already done so.
Okay, thank you.
Thank you.
All right,
Thank you.
So Dr. Shiva, thank you. Thank you for that historical walkthrough and a reflection of the journey of where we've been. Still lots of work to be done. And I encourage the colleagues to join the Public Health Workstream Committee with Dr. Shiva. I think certainly a huge task ahead of us. Our next talk is on capacity building initiatives as a strategy for developing a workforce responsive to community needs. There's been a slight change in the program. Dr. Rufino has been called to an urgent meeting, and Dr. Ivalda has kindly agreed to step in. And so we look forward to your presentation. Please go ahead.
Thank you, Dr. Natalie. Good morning again. So I will do this presentation on behalf of Dr. Rufino, that is the Director for Communication and Training at INS Mozambique. So this is just to share the experience of Mozambique, Mozambique and PHI on workforce development, looking and addressing inequities. So the indicators are mostly the health indicators in Mozambique comparing to the standard, or what we consider standards, are still far away from the ideal. If you look at the slide, look from maternal mortality ratios to life expectancy to under 5 mortality rates, we still need a lot of work. Including universal health coverage that we've been addressing during this meeting. And if we look specifically on workforce indicators, we can see here that when we look at, for example, physician density and epidemiologist per population, we still have a lot of work to do. And we comparing inside Mozambique, comparing rural and urban areas, we can also see a lot of inequities. We can see that although the majority of the population in Mozambique are living in rural areas, mostly 70%, the majority of the healthcare force are in urban areas. And when we look at specific and very important indicators such as delivery, we also see that in the rural areas we are still facing a lot of challenges, and other indicators such as vaccination and social indicators such as women education are still low in rural areas comparing to urban areas. So INS has a huge mandate. From biomedical research to reference laboratory services and systems, surveillance, as we've been mentioning, and health emergency and response. We collaborate, we coordinate and co-coordinate with the Ministry of Health. We have a division of communication and training. So this is definitely to show that we recognize the importance of training to support workforce development, not only at INS, but in the country in general. So what we do specifically, and this is from master's and PhD courses, medical, public health, medical specialization, short courses and scholarships in order to address inequities or support reducing inequities in Mozambique. So these are the different master's and PhD programs that INS coordinates in the country. From health science, we are coordinating the FETP program in the country, and health sciences and health systems masters and PhDs, and we can see the number of graduated and in training right now. And these are health professionals, not only from INS, but from all over the country. And we can see here, this is the most recent program that INS started to coordinate, and with a huge support from Fiocruz Brazil. There is the master's and PhD programs in health systems. And we have right now 42 graduates from masters and PhDs, and we were able to enroll health professionals from mostly all of the provinces of the countries, and we did a huge work in order to make sure that we had especially health professionals from the north regions and the central region of the countries that are the less developed, and they have less opportunities most of the times. Regarding the FET program, we started the program in 2010 with the advanced level, and we have more than 60 field epidemiologists already graduated, and we were honored to have 2 graduates or 2 students from Guinea-Bissau that were in Mozambique for 2 years that were enrolled in this program. And we already have also not only the advanced level, but we were able to complete the pyramid of the FETP. So we have the intermediate and also the frontline course that is very, very important, because we go to the district level and we train, although it's a short training, it's a 3-month training, but we are able to train the health professionals that are working at very remote areas in the country on basic training, such as using an Excel and research how to do basic statistical and interpret the data they are collecting routinely. So for the FETP, we also recognize that there are inequities still. The majority of the graduates, they are from the South region, especially from Maputo area, that is the capital of the country. We are doing a huge effort to make sure that for the next cohorts, we are able to have enrolled people from the north and the central region. But although we already have some of them, but this is the target in order to have 1 epidemiologist for 200,000 inhabitants. Regarding short trainings, we have trainings in different areas, from a lab to surveillance and surveys methodologies, research methodologies, risk communication, quality and management, and leadership also. And we've been training since 2016, and here we can see that we had a huge number of beneficiaries between 2020 and 2021. And this is mainly because of the COVID pandemic, where INS played a huge role on training from lab capacity also to surveillance. We open our institution to internships. We receive undergraduates also for different areas, and we are trying to have more and more contact with undergraduates from different fields of work, not only the medical field, not only the lab field, but also the social field, the geography, and other areas of importance in public health. We are able to provide scholarships for master's and PhD trainings students. Some of them are not full scholarships, but most of the times they're complementary. This is a huge challenge still, but we are able to provide some master's, PhD, and also postgraduate grants, and also scientific initiation grants for undergraduates also. And we are, as I mentioned before, we are not focusing only at INS workforce development, but we also need to make sure that at INS we have all the capacity needed to support all the activities that we do. So recently, INS Directorate approved the Human Resources Development Plan. So the idea is it's a 10-year plan, and we did some projections in order to make sure that the trainings and the opportunities that we give, they're not they are really to make sure that we focus on what is needed inside INS different specializations. So this is the projection for master students, and here the projections for PhD students for the next 10 years. And this is also to make sure that during this, the plan includes definitely addresses inequities. So we tried to make sure that we include in this plan people from all provinces of the country. So this is my last slide, just to share some of the perspectives for INS in this area. So we are aiming to establish the National School of Public Health. So this is a huge plan, and this plan needs to be approved by the council's minister. So we are working on that. We definitely need to make sure that we have the necessary resources to implement the INS Human Development Plan that I shared, and also, as I mentioned yesterday, we were nominated the Africa CDC Center of Excellence for the Portuguese-speaking countries in Africa. So we are now aiming to operationalize this activity for the next years. So thank you.
Thanks, Dr. Ivaldo, for that excellent presentation of the work that you've done, but also the state of the collaboration with peer groups. So, would you like to summarize, or would you like to open for questions and answer questions?
I would like.
Okay, perfect. So I'm going to hand over to my co-chair. It has been a privilege facilitating the session thus far. Please go ahead.
Thank you. Thank you, Natalie. Thank you. I think I was really sort of scared, afraid to do a wrap-up summary, because this issue of health workforce is so tremendously challenging. And as a matter of fact, Amer brought us such a comprehensive, wide need of intersectorial, interdisciplinary workforce that it really scares even more, because this is an absolute truth. We have a tremendous lack of so-called medical biological workforce. So when we want to include all those absolutely necessary fields of a workforce that Amer showed us, we really start believing that it is almost an impossible mission, although absolutely necessary if we want to move on. So I think the challenges Amer presented are the most important points we should consider, from which I noted resistance to change is a very important issue. And this resistance to change is probably linked to the very vertical sectorial ownership of knowledge sectors. So every sector wants to keep their own knowledge to themselves. It's very hard to integrate intersectorial learning and knowledge. And of course, the limited training programs and the funding constraint. And then we had this by Geoffrey Namara from WHO Berlin Hub, some solutions, particularly linked to exchange among and between the institutes. And I would really like to bring in Ivalda's presentation from Mozambique, because this is an example, exact example of interinstitutional exchange. In this particular case, not only, but mostly with Fiocruz, which we represent, and INS Mozambique. She did not mention that when this movement started about 15, 16, 17 years ago, INS had about 30, 35 staff members and maybe 2 imported PhDs, that is imported Mozambican but trained outside. And now you see that 10 years later, this extensive, tremendous construction, structural cooperation. And this, talking of this structural cooperation, then we can bring in Shiva's words, which are so optimistic. He's the best fighter of, we would say, the slogan, yes, we can. He's always optimistic and he knows that we can. Means are there. We should just try to work on them. So I believe that in all those presentations, we had really examples that things can be done. And this partnership between institutes, and this, the only thing I would like to add here is that the importance of networks, of networking. And networking, we have many examples of regional networks, that is geographic networks, like the African, European CDC, etc. Then we have the ethnic language networks, like in our case, the Portuguese-speaking network, which is a small network made up of 8 countries, but which is tremendously active. As a matter of fact, we are having tomorrow morning a parallel session on the CPLP network, where these issues, for instance, the epidemiology training program, which has been suggested to be created for the Portuguese-speaking people by the director of the Institute of Cabo Verde, who is here joining us. And we have then in Mozambique now a place, a site where this program for all of the members of the network would really take advantage and work with it. We also have with IANPHI the regional networks, of which we have the Latin American network, which has created, for instance, some examples of exactly the interdisciplinary work which has been put forward here by Amer, by Shiva, and which here was presented by Bernardo and by Carlos Hernandez from El Salvador, which is a innovative project of community participation for primary health care to gather students, primary health workers, and National Institutes of Public Health. So the means are here, really. The way is to have innovative, progressive approaches to that. And in order to do that, sometimes we will have to cut very solid links to traditional means, trainings, and curricula, which certainly have to be changed in order to incorporate all the needs which here have been placed. So I think after all these very rich presentations, I would like to open to you for questions and comments, particularly comments, and maybe examples that you members would like to put here and complete this session. Thank you.
This is such an important issue. The workforce is absolutely critical to the future of public health. And I suppose it's trying to understand what it is IANPHI can do collectively. So one of the important partnerships that we have as IANPHI is with schools of public health. And I think it's critically important that we mobilize the assets that we have in every single country and have that strong collaboration. Because it's only when schools work with the institutions that are going to employ the future public health workforce that we will have that true partnership. The other critical thing that's happened, and it was touched on by several presentations, is the WHO roadmap on building the public health and emergency workforce is critically important. It has 3 key steps. Clearly, we need to map and measure the existing workforce. We also need to ensure that that workforce is trained with the skills and competencies needed to deliver all of the essential public health functions. And then we have this experiential learning, the link between the schools and the institutions to make sure that people get experience doing the job that they're being trained for. So for me, we hear about lots of initiatives, and it was great to hear from sort of the Berlin here, but on the work that's being done on mentorship to build capability in leadership of emergency responses. But we need to recognize that is a subset of the workforce capability that we need. And we need a multidisciplinary public health workforce that can, yes, do emergency response with capable leaders, but we also have the public health nurses that do the footwork. We have people who work on One Health. So it's developing that curriculum that serves the entire competency needs of a broad multidisciplinary public health workforce, where NPHIs need to work with other sectors and with multiple training institutions to make sure that we have the training capacity that we need. So I think one of the key challenges at a country level, where you often have a division between ministries of health and ministries of education, is to bring these groups together in order to support that. So it's fantastic to see the progress that Mozambique has made in mobilizing those assets to produce a multidisciplinary workforce needed to meet the country's needs. And as you say, the examples of where that has happened, I think, will be great for other countries that are embarking on that process of developing their public health workforce. So just to thank you to all of the speakers. I think this is so important for the future of public health.
Thank you, Neil. I'm going to take any other comments or questions before we pose it to the panel. Please go ahead. Tracy, noted.
Good afternoon. I'm going to speak in Portuguese. Obrigada. Sou Maria da Luz Lima, do Instituto Nacional de Saúde Pública de Cabo Verde. Também quero felicitar esta sessão, esta mesa redonda de suma importância para o desenvolvimento dos Institutos Nacionais de Saúde Pública, particularmente os institutos mais recentes que estão ainda na fase de consolidação, como é o caso do Instituto Nacional de Saúde Pública de Cabo Verde. Dois aspectos que eu queria ressaltar aqui, não é nenhuma questão específica. Um é sobre o impacto do treinamento em epidemiologia de campo nos países africanos de língua oficial portuguesa e a importância e a relevância do trabalho dos epidemiologistas de campo nos diversos níveis para o reforço dos sistemas nacionais de saúde e que, a nível desses países, do qual Cabo Verde também faz parte, têm sido liderados pelos Institutos Nacionais de Saúde Pública. E tem sido uma experiência muito gratificante, a partilha de experiências e todo o trabalho que se tem feito, mas ainda precisa ter melhor alicerce e dar uma força, uma mais-valia, porque a nível da nossa região, a língua portuguesa é oficial, mas a maioria dos documentos e das formações são feitas em inglês ou em francês, o que às vezes dificulta o acesso a essa formação. E tendo Moçambique bem estruturado, Cabo Verde também está a se estruturar, bem como os outros PALOP, isso vai ser de uma relevância fundamental. Outra consideração que eu queria fazer é relativamente à abordagem saúde única, que foi aqui também falada assim muito geralmente, a abordagem multidisciplinar, como o colega anterior disse. A experiência que nós temos em Cabo Verde é que é uma abordagem que faz muita diferença também. É importante que as três saúdes, a ambiental, a humana e a animal, falem na mesma linguagem. Sobretudo ter um acesso a dados, porque os Institutos Nacionais de Saúde Pública têm essa capacidade de analisarem as informações e fazerem esse link, serem inteligência sanitária no contexto de análise de tudo que determina a saúde e a própria saúde. Isso ajuda a tomar, apoiar, fortalecer os sistemas nacionais de saúde, que é para isso que nós existimos. Então, a abordagem multissetorial, que eu acho que deve ser reforçada no contexto da abordagem Uma Só Saúde, que a nossa experiência tem dado essa justificação, porque em Cabo Verde é o Instituto Nacional de Saúde Pública que coordena essa plataforma. Tem pesquisa, tem formação, tem laboratórios, tem tudo que essa plataforma necessita para permitir esse diálogo e também dar respostas necessárias para os problemas que acontecem relacionado com a saúde ambiental e com a saúde animal, porque no fundo estamos no mesmo ecossistema e os problemas têm que ser geridos nesse contexto da multissetorialidade. Muito obrigada.
Thanks. There's a comment. Tracy, I'm going to ask you for your comment or question, and then I'll hand it over to the panel.
Yes, thank you, Natalie. And just to say, firstly, thank you to the panel for really excellent presentations. I think we all resonate with them. So thank you. It was just a couple of comment question. I violently agree with your comments. And so we have a phrase around public health science, which includes the specialism of public health, as we would traditionally recognize it, data science, behavioral science, and implementation science, that we see as now modern day expertise that needs to be embedded right across our organization. And you also included economic science, I would say, in that. Well, so that has to be how we diversify, and it links into my next point, which is about AI. So we have been having discussions internally consider in the next number of years if our colleagues in government, our civil service colleagues in government, feel that they can just use an AI tool to ascertain all the evidence to answer a public health question, then what public health expertise do they need from national public health institutes? Now, I'm being controversial, but we could be in that situation. So it's how we think ahead of that. And so what is the diversified expertise that we need that will help decision makers, help ministers, but also being really clear what is the added value of that expert judgment that needs to consider all of the evidence in the round and the given time in a country to inform the right decision, not just what has been generated from AI. So it's a question to ask the panel, what are your thoughts on that? And then my final point is about relationship management, which I think both Shiva and Felix referred to. We work in the gaps often, don't we? Bringing partners together. And it's a real skill. Not all of our people in our organizations have got that skill about being equal partners, and that actually, the goal may have to some give and take to achieve improvement in outcomes. So relationship management is just so much at the heart of this as well. But just interested to hear the panel's thoughts on the AI comment. Thank you.
Thanks, Tracy. I'll hand over to the panel now for the input and response. Can we start, Dr. Mir?
Thank you. Can you hear me?
Yes.
All right. Thank you. Thank you so much. I think some very valuable comments. And Tracy, definitely, we need to draw a line. I mean, it's a big debate about AI, for how long and how much. And as we truly understand, the human elements must remain above AI. That's something important. And I think as we've seen the scientific developments in all the fields, now this is a debate, how much of AI, because we don't want AI to control us. It is the human element which has to control. AI is just a helper. So I think similar things are being discussed on the medical side. And I think public health domain, it remains a question. So I think IANPHI may be the platform where we can start this debate that, I mean, as pointed out, it's not the global health, it's the global public health. I mean, whatever the terminologies, I think we need to understand the intricacies, and AI, we should not let AI control us. And I think open for a discussion for IANPHI, and we will, well noted for future thoughts. Number two, as far as the field epidemiology is concerned, I think it has been great because the TEFINET, which is the training network from CDC US, being run in more than 120 countries again, just like IANPHI. And fortunately, I happen to be the chair of their advisory board. So I think they were the soldiers on the ground during the COVID period. And it was great to see their efficacy and work during that period. And once coming out the COVID, there were thoughts, but we also put that the 2 years advanced course is really great, whereby we have very much trained workforce. And now is the time that we may be having subspecialties like One Health, like AMR, like by safety and biosecurity, and moving on to climate and all those things. And some of the countries like UK has already started working in climate. Some other countries have started working on shorter courses on One Health. And it's great and fascinating to see the 8 Portuguese-speaking countries coming together. And let's see what's the outcome tomorrow. And I think very rightly pointed out by, again, Neil as well, that the time has come. The networks are there. We need to form network of networks. I think that will be the success. The strength, as I pointed out in that schematic diagram, that how we can help WHO. We have got the human resource. I think maybe TEFINET joins hand with IANPHI, IANPHI joins with TEFINET, and we share the strengths. And definitely that will create the momentum, and especially under the new financial constraints. So I think that's a good food for thought, and we must continue. And networking and collaboration can make a true difference. Thank you.
Colleagues, we're heading for lunch. We are all very passionate about this topic. May I request your indulgence to go over by about 5 minutes? Is that acceptable? Yes? All right. All right. Thanks. So Shiva and then Felix.
I think Neil, our new secretary for IANPHI, brought up this issue of the importance of focusing on the health workforce. The success of WHO in the past was the workforce. They trained a lot of public health. Some of us trained in the 70s and 80s because of WHO. And today, WHO's focus in public health and workforce is a bit weak. Second, WHO's focus on building health systems is also very weak. It produces guidelines after guidelines, meetings after meetings. The WHO I used to know and work with successfully in the 80s and 90s was WHO embedded in our national health services and helping us build systems. And one of the areas of their success was two things: primary health care, and it's not village health workers alone, but a whole community multi-sectoral approach. It's got a very foundational element, and not just community systems. The other one was public health and good infectious disease control, not the infectious disease control we have where diseases are out of control. Coming back to the point made by Trudy, public health has been marginalized by globalization the last 20 years or more. It has been in favor of hospitals, whether it is in Europe or in Zimbabwe or in Southern Africa. We spend too much money on hospitals and medical care. So we have to really look at this urgently to say, how do we refocus quickly? We lost the opportunity of COVID. I'm sorry, we've lost the opportunity of COVID. We need to get that opportunity back. Thank you. Sorry.
Felix, do you want to add a comment to that?
Yes, just very quick comment. First of all, just say that Portuguese-speaking countries are not coming together. We have been the first network within IANPHI immediately after IANPHI was created. We created our network in 2010, and we really were probably the first example. At that time, IANPHI was a little bit, I would say, a step backward, because how would be competitors? And then IANPHI understood that those networks are networks which support IANPHI because they get together people who have some type of common links, either cultural, geographical, or whatever. Just to mention that this, first of all, when we speak of public health workforce, we have to define what is public health workforce. And this here you have been put forward all these different disciplines, and this have to be really worked. I just want to show very quickly the example how we have to have in mind this type of discussion we had here. This epidemiology, field epidemiology program is a very vertical program, which has been excellent and very important for everybody. But it has been sort of, disciplinary speaking, one-minded. If we have now the opportunity of creating new field epidemiology, including these facts we have discussed here, we have to include social workers in these teams. We have to include geographers in these teams, because then we will have really field epidemiology from a point of view of intersectorial and transdisciplinary, and having community actively really participating. And so I would just like to mention that we have to think every time we put forward a plan or a program, think about these needs which have been put here. Then we will probably go forward faster. Thank you.
There's a question on the chat, and I think if we answer this question, we'll be here for dinner. So I'm going to read it, but it's certainly food for thought. The heart of all activity lies in human beings, and this is especially true in health. Considering the need to restructure and invest in this multidisciplinary and intersectorial public health workforce, how can we at IANPHI, our institutes, support and generate advocacy more decisively to improve their professional and working conditions, prevent the loss of specialized workforces, and guarantee adequate and stable public health responses? And certainly the answer to that question will keep us here all night. I want to thank my esteemed panel members for their excellent contribution, for the audience for your active engagement, and I want to leave you with a thought. Shiva mentioned the happiness index. If you just think and reflect for a moment, what is your happiness index? What is your fatigue index? And compute these numbers. But what is your influence index? And what is your energy index? Because if you multiply your influence index and your energy index, then it really doesn't matter what your happiness index or your fatigue index is. Because where your focus flows, your energy flows, and you can influence and make a difference in this important topic. I thank you and enjoy lunch.
So before you get out of the room,